So without further ado, Dr. Kestenbaum, welcome.
Thanks, Matt. Thanks everybody for being here on our first day. You see a lot of faces. It's great to see. Hopefully we'll be seeing you in person sometime soon. Looks like ASN might not be happening though. I'm gonna have to wait even a little bit longer to see some of you. Let's see, I guess without any further intro stuff, let me go ahead and share my screen, make sure this is all working here. All right, can everyone see this okay?
Yep, looks good.
All right, well, I'm talking about something different this morning. This is population-based limits of urine creatinine excretion. And this really is an example of something that happens when you're working on a research project and something comes up in that research project that then leads to something different. It's a little bit of a side dish. It's not groundbreaking mechanisms of some kind of kidney disease or anything like that. It's sort of a type of thing that you'd want to figure out to get another research project working well. I'll explain what I mean. So I think people have heard some of this beginning about tubular secretion and the stuff that my research group is working on. We all know that the kidneys do many important things, from filtration to secretion to synthesis and other things, but that when we go to assess kidney function, either in acute kidney injury or chronic disease, our assessment is pretty much limited to the glomerulus in terms of the filtration of freely circulating solutes and the integrity of the glomerular basement membrane. So GFR and albuminuria are our tools. We know that the secretion by the tubules is a distinct process from glomerular filtration that might tell us something else about the kidneys if we could develop ways of actually measuring it. And tubular secretion is a complicated process involving the intricate hemodynamics within the kidney and the post glomerular capillary, the movement of things through the interstitial space. It requires energy and specialized transporters. And so for all these reasons, we think that developing facile methods to measure tubular secretion would be helpful in the future. And my group has been working on this. The basic approach we've been taking is we say that if you can find something that's made in the body, an ideal secretory solute that's an avid substrate of the transporters on the proximal tubule, if we could find such solutes, ones that are not filtered to much of a degree, are avidly secreted and can be measured, we could measure the kidney clearance of those solutes and use that as an estimate of secretory solute clearance. We've been working on this for several years now. These are some of what I'd say are sort of top candidates, the ones that really seem to perform very well in all the studies that we've done so far. We're in the process of actually discovering new ones in a big metabolomics project. We have some other candidates, but these four tend to do really well as markers of secretory clearance. Canurenic acid is one in particular. It's highly protein bound, so probably not filtered to too much of a degree, but it's avidly cleared by the kidneys, and it's pretty pretty easy to measure in terms of good quality and repeatability. Now, I'm slowly building up to where this new problem came in. So for estimating glomerular filtration, we have serum creatinine. And one of the nice things we have about that is over the years, they figured out that because serum creatinine comes from skeletal muscle, they could estimate to some degree its production based on age, sex, and maybe self-reported race, maybe not so much now. And because we have a way of estimating the production, may not be perfect, we can rely on the serum level alone to estimate its kidney clearance. We don't have to get into the whole creatinine clearance in every patient. We have to send every patient for a 24-hour urine anymore. We can estimate GFR this way. But when it comes to these new markers where we're trying to estimate tubular secretory clearance by their clearance, I don't know what characteristics influence the serum canurenic acid level. And so for that reason, we are still back maybe 50 years ago with creatinine, with the markers we have, in requiring measuring actual kidney clearance of these markers to estimate secretory clearance. So when we get when we estimate tubular secretory clearance from a kynurenic acid level or a pyridoxic acid level, what I mean is we're getting a timed urine collection, and we're getting serum and urine kynurenic acid or pyridoxic acid, and we're actually calculating UV over P. And of course, the kidney clearance of a substance is theoretically independent of its production. So it should be telling us, in theory, if it doesn't violate the steady state assumption, what the kidney clearance of that substance is over some unit time, and inform us about this tubular function. So we had this hypothesis somewhat early on that lower secretory solute clearance would be related to the long-term progression of CKD. We were in the process of testing that in a large national study, the chronic renal insufficiency cohort study. And this had about 3,400 patients at the beginning of the study who did a 24-hour urine and had available samples for measurement. And they were followed for years for their progression to chronic dialysis or doubling of creatinine or other outcomes. So we had proposed and did add the clearance of these secretory solutes to CRIC at baseline and evaluated whether they were associated with worsening of kidney disease over time. And they were. But I'm going back now to one of the first things we saw. When we just started taking a look at some of these clearances, one of the things that struck me was there were people in these studies who had very low values. And for kynurenic acid, for example, 1% of the values were less than 20 mils per minute. And I point them out with the arrows here. I'm not as concerned about the ones to the right, the sort of unusually high ones. They're of concern too, but of course, we're always worried about under-collected urine samples. And again here, we have to rely on timed urine samples at this time because we don't have an easy method to measure these things from plasma levels alone. So I thought, let me take a look at some of these abnormal, or at least some of these very low values. What's going on? And one of the things I noticed when I just started listing them out is that their 24-hour clearance of creatinine, or the 24-hour production of creatinine, this is just the 24-hour urine creatinine in milligrams per day, was quite low. Some people had 160, 340, this one 237, and they weren't particularly small people. They had normal looking weights, and some of them had normal looking urine volumes, but these 24-hour urine creatinines were low. And from what I learned as a fellow, if the 24-hour urine creatinine is low, maybe the collection is an under collection. So, okay, I thought, well, I learned in fellowship that if I should check the 24-hour urine creatinine excretion in the sample, and if it's between 15 and 20 mg per kilogram in women or 20 to 25 in men, then the sample's okay and I can keep it. Otherwise, I should maybe repeat it or do it again. Of course, I can't repeat it here. It's a study, so I might have to exclude them. So doing that got rid of 2,756 people, or 81%. In other words, 81% of the 24-hour urines in the sample did not have a 24-hour creatinine excretion that was in those ranges. And I thought, how could this possibly be? I checked some other studies that had 24-hour urine creatinines, and it's the same thing. So then I was thinking, wow, everything I just learned about how to judge the validity of a timed urine sample might not really be true. At least we must really be quite liberal in terms of how we stretch these numbers in practice. I then found this on the UCSF Lab Medicine website, and it had exactly these more liberal criteria for judging the efficacy of a 24-hour urine. It said if the urine creatinine was between 14 and 26 mg per kg in men, or 11 to 20 in women, you can consider it to be an adequate sample, and it gave this reference. So I went ahead and tried that, and that excluded 44% of the people. So I emailed some friends that work on projects that involve 24-hour clearances and said, what do you do when you get some of these things? I don't want to include some of these obviously under-collected urine samples. And someone said, we just, if it's greater than 8 in men or women, we keep it. If it's less than 8, we throw it away. But they said, I don't have any data for that. And someone else suggested maybe keep if the 24-hour urine is over 500 milliliters in volume. it's making me think that we don't really have a really reliable way of assessing this. So how do we decide if a 24-hour urine is actually valid or not? Is there a gold standard? Maybe not really, but there is something that has been done to assess 24-hour urine collection validity. They give people an oral dose of this chemical para-aminobenzoic acid. It's actually part of sunscreen, and it's in other compounds, and it's rapidly absorbed, very high bioavailability, and rapidly excreted in the kidneys. And if you do that right before you do your 24-hour urine in people, you can look to see how much of the PABA comes back and use that as a way to judge the validity of a timed urine collection. Of course, the problem with that is this is really impractical, and it's only going to be useful to judge an undercollection, not an overcollection, and it makes a lot of assumptions about how this particular compound is handled. So if there's no way to actually know the truth about whether a 24-hour urine collection is valid or not, whether or not the person did it correctly, or the researchers did it correctly in the setting of a study, it's both, we can sometimes rely on population-based limits. And we do that for many lab tests, right? For sodium, we see these normal values. For chloride, we see these normal values reported with the lab. And what those really mean is that they measured them in just massive numbers of people and found the upper and lower 2.5% of the distribution. And that's where those come from. So can we do that for 24-hour urine creatinine? Could we go back and really find the actual limits of urinary creatinine excretion? Well, it's not that simple for urine creatinine excretion because these things depend strongly on body size. Depends on weight and height and sex and things like that. So normal would have to be, those population-based limits would have to be, the lower 2.5% limit for a 52-year-old man who weighs this much and is this tall and is this old. So it's a little more complicated. Now, there have been many, many studies that have tried to understand normal urine creatinine excretion, and that's where the 15 to 20 and 20 to 25 come from. Here's a handful of some of the better ones. And what those studies have shown us is that weight, height, sex, age, and other things, mostly though those first four, are helpful for predicting the average 24-hour urine creatinine excretion. But they don't give us any real sense of what those upper and lower limits are. Those calculations were not done in a reliable manner. It's hard to estimate limits when you're trying to do it with sort of conditioning on these different other characteristics. And the studies I showed you were largely white, mostly small, and most of them actually did not have people with kidney disease in them. And that's an issue because we often, at least in nephrology, are told to or actually do get creatinine clearances as people approach dialysis with end-stage kidney disease. And in practice, you've probably noticed that you often get back a 24-hour urine creatinine excretion that's on the lower side there, and think, oh, I wonder if that person didn't do an adequate collection. But then I also wonder if people with end-stage kidney disease, as they approach dialysis, their muscle mass is low, they have other illnesses, maybe that's normal for them. And the studies that have been out there have not really included such people to be able to make a good assessment of that. So in the middle of working on secretory clearance, I had to stop and take a break and do an entirely new project because I thought we needed to redo the whole thing. And I do this sometimes, and it's a fault because sometimes it's best to just move on. But I was not happy with the existing methods to assess the validity of a 24-hour urine sample, and I wanted to do it over again. And I wanted to estimate reliably the upper and lower bounds of urinary creatinine excretion. I wanted to do it in a large, diverse study population, and I wanted to make sure there were enough people with kidney disease in there to get a handle on that characteristic. So I chose 4 studies. 3 of them came from the NIDDK repository, and 1 came from a number of phone calls. These are CRIC, MDRD, Jackson Heart Study, and PREVENT. And you can see here the number of people in these studies. These are studies, all studies in which coordinators collected apparently carefully collected, carefully measured 24-hour urine samples, meaning that they gave people instructions several times about how to do a 24-hour urine collection the right way. They gave them containers. The coordinators took the urine when they came back. They asked them how they did it, and then they went ahead and filed it. And so we had 24-hour urine samples, data from 24-hour urine samples in 13,942 people, a pretty wide range of age. There were 2,652 African Americans in this group, and 4,446 of them had kidney disease, at least defined by a GFR of less than 60, and many of them with actually significant disease. Of course, first problem we ran into is everybody measured urine creatinine using a different assay. And so we had to come up with some system of calibrating these assays, and we used, in some instances, direct calibration, and in other instances, indirect calibration. So what do I mean by that? So for the example of CRIC, where we did direct calibration, we asked them, could we please have 100 or so of your urine samples that you might not be using? And we selected them on a basis of having a wide range of urine creatinine, and they sent them here, and we remeasured them, and we compared our urine creatinine measurement with their urine creatinine measurement, and we made an equation. So that's direct calibration. And if you remember, Andy Hoofnagel came here and gave a talk a year or two ago about how urine creatinine has just been recalibrated to new IDMS standards. And so we wanted to make sure that when we did these calibrations and talked about what normal urine creatinine excretion should be, we wanted it to be on the scale of the new standards, because that's what hospitals are using now. So we did this indirect calibration for 2 of the cohorts, and then we indirectly calibrated the other cohorts by adjusting to the calibrated cohorts and including adjustment terms that we factored into the analyses. We divided our cohort into discovery and replication. We used this thing called a gamma generalized linear model, because what we're trying to figure out as we're doing this is not so much what's the average urine creatinine excretion for a person of a given age, race, sex, height, weight. We are interested, of course, in what the average is, but we're mostly interested in what those upper and lower boundaries are. And so it's really important when we do the modeling to understand the error. So from the average, we can come out and estimate those boundaries well. And this particular model gave us the best capture of the error structure of the data, and allowed us to indirectly calibrate our urine creatinines on a multiplicative scale, which is how assays usually differ. And we had predictor variables of interest shown here: height, weight, sex, age, and serum creatinine. Here are characteristics of the discovery and validation cohorts. It's got a wide range of, we had a wide range of age. About half the people were women, 19% overall, had self-reported Black race. The weights and heights here span a huge range. They were about 9% of people with a GFR less than 30. It's not huge, but there were still hundreds of people there, enough to get some sense of how things work in a group like that. The urinary creatinine excretion on average for the entire group was 1,338 milligrams per day. And there were some people that had albuminuria, but not too many. One interesting feature in the pre-bend cohort, they asked people to do their 24-hour urine collection again, an average of 3 weeks later, and they determined how much intra-individual variation there is in urinary creatinine excretion. And they came up with a value of 11%, with a range of interquartile range of 5 to 22%. So that's the median change in a short time period. All right, so let me ask people, I've been talking straight through. We looked at these characteristics to see which was the strongest, second strongest, third strongest. What do we think the order here is? Which characteristic is the strongest characteristic for predicting a person's 24-hour urinary creatinine excretion? Anyone have any ideas?
I'll guess height.
Got height.
I was going to say age. And what you don't have, Bryan, here is vegetarianism.
I know. If we could get diet, reliably get an assessment of diet, we would use it. I mean, we had things like DEXA and good high tech stuff. It only in small groups and some subsets with dietary assessment too. But it's just not practical, right? To apply this outside. So I got a vote for height and a vote for age. Any other votes?
Well, there's one not on there I wish I had, and that's muscle mass, which I'm curious about correlation.
Yeah.
I might say weight and looking at the patient to see if it's mostly fat or mostly muscle.
Absolutely. So muscle mass would be perfect. There were DEXA estimates of muscle mass in one of the studies, but again, in only a small number. So we couldn't really, use that outside. And even looking at DEXA estimates of muscle mass, though, it wasn't as groundbreaking as we would have liked. Maybe the test isn't as great in study setting. So I've heard
serum creatinine, Bryan.
Okay, I've heard everything but the answer. Serum creatinine, age, weight, height. So it's sex. On a statistical basis, you want to look at what has the strongest impact on a person's 24-hour urine creatinine. Just the binary variable of your biologic sex is stronger than the continuous variable of age or of weight or age or height. So it's sex followed by weight, followed by height, followed by age, followed by serum creatinine, and self-reported race, once you have these other things in the model, does not contribute, at least not in a significant or meaningful way. So this is the building of the model in the discovery cohort. This is what we did in the 9,199 people that were in the discovery cohort. We considered the models to be improved if the AIC or the ACLI, oh no, I forget the I, information criteria was reduced, or there were improvements in some of the other parameters, or if the graphical inspection of the plots demonstrated that improvement was there. So all of these characteristics improve the fit. Here is shown as the one of the first things we found out, though, is that once you account for sex, that the slopes of the other characteristics are different by sex, and so sex-specific models are needed. So there was something right about the old way of saying it's 15 to 20 in men or 20 to 25 in women. This idea that it's different was true. And so the height and the weight and the age, they're all separate, modeled separately in men and women. We looked for a interaction term of height times weight to see if that added, and it didn't. And again, self-reported black race also didn't add. Okay, and serum creatinine was interesting too, because what we saw there was that for lower values of serum creatinine, that as serum creatinine went up, it portended a higher urine creatinine excretion, probably telling us something about a person's muscle mass. But once they got kidney disease and the creatinine hit a plateau of about 0.7 in women or 0.9 in men, then as the creatinine went up, the creatinine excretion starts to go down as they probably got sicker with kidney disease, and muscle mass was getting lower. So a final set of equations, one with creatinine, one without, were derived from this discovery cohort. And once we had these equations, we then wanted to ask, well, how well do these fitted equations do in a replication cohort of 4,599 people who have never seen these equations before? And what's shown here are the residuals for those two equations. The equation that just had sex, weight, height, and age in it, the ones that had sex-specific terms for those factors. The difference between what was predicted and what actually came out, the person's actual 24-hour urine creatinine excretion, was the median was 4.3 milligrams per day, and the 95% confidence interval is 5.6 milligrams per day less, and 13.3 milligrams per day more. So the equations are getting somewhat close to an actual urine creatinine excretion in the replication cohort. This is the bias. So what we're looking for here is we come up with these equations in the discovery cohort. If we then apply them to the replication cohort and they're systematically off, like it's always coming out low or always coming out high in a specific group, that's when we worry about the equations from discovery being biased. And we didn't see that there was any bias by sex or by self-reported race. But what we did see is that the equation that didn't have serum creatinine in it does have bias by kidney function. In people who had advanced CKD, the equation was over-predicting their urinary creatinine excretion. In other words, people with advanced CKD, their 24-hour urine creatinine excretion was coming out lower systematically than what was predicted by the equation that didn't have creatinine in it. The equation that did have creatinine in it, it reduced that bias substantially, though there's still a small amount remaining. Finally, to get a sense of whether or not this equation was doing anything useful, it turns out that there were about 700 people in the validation cohort from both MDRD and CRIC who underwent iothalamate clearances to measure their GFR. And so we're interested in what's the agreement between IGFR and creatinine clearance before and after applying these exclusion limits that we came up with. So first off, in these 700 people who had IGFRs measured, if we take all the 24-hour clearances, we don't put any limits on it, take everything that comes, this thing called the RMSE is 20.8. And the RMSE is basically a measure, an estimate of the distance between the creatinine clearance and IGFR for a typical person in the data set. So you could say that it's a little bit different than that, because it's actually squaring things, then it's unsquaring them. But you could sort of roughly say that if you don't do any exclusions on 24-hour urine samples and count them all, the creatinine clearance is about, on average, about 20 mils per minute different than the IGFR. Progressively excluding 24-hour urine samples that are outside the limits made by the equations improve the agreement. And what we saw is that if you exclude urine collections that are supposedly over collections, these are collections that had 24-hour urine creatinine excretion that was higher than that of predicted, you do get an improvement in fit at the beginning. But if you keep lowering those upper limits, it doesn't really improve the fit any further. So there's really no need, at least in terms of agreement, to go exclude 24-hour urine samples that are potentially artificially high above the 97.5% limit, at least using this equation, but not so for undercollected samples. For potentially undercollected samples, the higher you draw the cutoff, the closer the agreement between creatinine clearance and IGFR. And for this reason, we selected this particular balance of lower and upper limit as a suggested set of cutoffs for assessing 24-hour urine collections, if they're below the 5th percentile of the predicted lower limit or above the 97.5th percentile on the upper limit. Shown here is David Prince, one of the biostatisticians at the KRI, who's helped develop an app for this. As of right now, the icon is a little bit on the plain side, but I have it on my phone, shown here, the urine creatinine calculator. And it's still in production here, but basically it's going to look like this. You will go to it. You can input, in the case of the simple equation, the one without creatinine, and you'll be able to pick which one you want if you have creatinine available. You can type in the person's age, their weight, and their height, and their sex. And so what the program will return is, you might type in that you've got a 52-year-old woman who weighs 147 pounds and is 65 inches tall, and the app will tell you that for that person, the expected lower 5th and upper 97.5 percentile for urinary creatinine excretion is 476 to 1,651 milligrams per day. If you get values outside of that range, you might consider that the sample was under or over collected. Okay, so to summarize, we developed and validated models to predict the limits of urinary creatinine excretion for assessing the validity of a timed urine sample. We did so in a large, diverse study population. It wasn't as large or diverse as I would have liked, but it was a good start, I thought. And we have the sort of infrastructure to keep improving it if we can get more data. We used calibrated urine creatinine measurements to the newest IDMS standard. And we include a second model that has kidney function in it for use in advanced CKD to try to help with the problem of potentially lower urinary creatinine excretion in that setting. There's a couple of big limitations. One is that even with idealized modeling of sort of anthropometric and demographic characteristics, we're still not explaining that much of 24-hour urinary creatinine excretion. So there's a lot of other characteristics. Perhaps if we could measure muscle, skeletal muscle well with some kind of a test, we would get better. And there may be other things that influence a person's serum creatinine level besides just their skeletal muscle mass. And those are not readily available in practice. And we still have issues of potential external validity. These studies are still research studies. Some of them were population-based, others were clinic-based. They were somewhat specialized in who entered them. And so we still, I think, would be better with more data from more broad groups of people. But this is our sort of place to shine and sort of be the king on top of Trash Mountain, which is sort of what we said when we were submitting this paper, which is that given the fact that the other methods don't really try to do estimation of these limits much at all, and were done in small studies and had these other limitations we talked about, we think the limits derived here represent the most valid and representative way of appraising the utility of a time during collection. I want to thank the people who helped work on this. Some of our Dutch colleagues here from Prevend, the NIDDK repository. Thank everyone for their attention, and I'll stop and take questions.
Thank you so much, Brian. I think, unfortunately, for the purposes of time, I think we need to move on to the biopsy conference. But thank you so much for being the inaugural speaker. So